Hello, everybody. I read Paul Rugger's book, The Cost of Cutting. A surgeon reveals the truth behind a multi-billion-dollar industry. He begins the book talking about the high use of CTs and MRIs, which leads to incidental findings, um, which increases the need for increased radiology exams. He goes into we saying that we spend $100 billion a year on medical imaging related to those tests, CTs and MRIs, increasing and finding non-specific incidental findings. Unnecessary surgery accounts for 150 billion a year. That's from the University of Michigan from a study. And all of these things put many pressures on the surgeons to operate more when these things are found. And surgeons really should only take a person to the OR based on medical facts, sound judgment, and experience, but that gets a little bit gray, in particular when patients are really advocating for themselves to want to go to the OR, even though maybe that's not the best course of action for them, per the surgeon. There are many pressures by business factors to keep ORs open and very busy throughout the day. The line between operating for love and money is blurry. That was a quote from Dr. Ruggieri, which I really liked. Some surgeons are very motivated by money. Maybe some not as much. It said doctors make poor business people because they have a failure to understand the business side that can negatively affect patient care. And unfortunately, global payments and rewards on quantity and not quality necessarily is becoming somewhat of the norm. Although I would say in my healthcare facility, while we do have some focus on quantity, we talk about quality every day. And that includes in the OR setting as well. He describes that today is a world of selling surgery, needs to work for corporate medical systems that have constant pressure to meet their salary and their quotes, and this puts a lot of pressure on surgeons that do surgeries that may not have done them in the years past, or it may be a surgery they haven't done in a while, or maybe just weren't 100% at, and that can cause complications. Dr. Ruggieri describes this act of surgeons doing that to patients as criminal. He also goes on to say rising costs in healthcare can be attributed to many things. One of them is money spent on a person's last year of life. A third of Medicare dollars is spent in the last 6 months of a person's life. A lot of those patients undergo operations, which at an advanced age is associated with a higher mortality rate. This means more time in a critical care unit, which means more cost. This happens pretty frequently. I have seen it a lot, being in a critical care unit. And I've not just seen it from surgeons, but I've seen it from families really pushing for surgery, patients really pushing for surgery, maybe not understanding exactly what that means. But I've also seen it from the cardiology side in interventional radiology or interventional cardiology as well. So I don't think that's just for surgeons alone. The concept of reimbursement for cost efficiency, quality outcomes, and not just bulk surgery is likely to decrease healthcare costs, was one of his strategies that he mentioned in the book. And then he questioned how can we reduce unnecessary surgery, and publicizing surgeons' outcome data as related to cost and pay them for less and poor quality outcomes. Second, reduce reimbursement for elective operations that do not have solid medical data and pay surgeons less who operate using that dubious data per Dr. Ruggieri. The scrutiny of outcomes may come at a cost for patients, though. It would cause a surgeon to what he calls cherry pick patients. And these are surgeons that are in private practice that are not accepting Medicare patients, maybe because the reimbursement is too low, etc. But he's heard elderly patients, physicians tell elderly patients that they can no longer come and see them as a surgeon because Medicare was no longer paying them. So I myself, as a new grad nurse, witnessed something very similar to this. It was a physician in primary care who had an elderly patient that was frequently admitted, and he told her basically flatly in the room that, unfortunately, I'm not able to see you anymore. There's no more reimbursement for you. And it was something that the patient was very confused about, the family was very confused about, and really it was a big ethical dilemma for me. And how do I support that patient and that family? So it's very upsetting for all involved. Let's see. So Dr. Ruggieri goes on to discuss that, patients who self-pay are often charged a higher rate for hospitalizations. like they had a top tier private health insurance. That's part of our free market at work. Patients need to start negotiating or get a second opinion. For a patient to negotiate, they need to know what a normal price offering would be, and that's all over the map. Transparency, when this book was written, wasn't an option. Hope that will become more of an option for patients. Most physicians, including surgeons, are owned by corporation or healthcare systems. I know there's a lot of those in our Kansas City area. When physicians refer their patients to specialists or surgeons, they typically are referred to a patient that's linked to them financially or professionally. And this happens even when there are more experienced or competent surgeons or other specialists out there, unfortunately. Also found in corporations or large healthcare systems are supply contracts. These can be helpful to keep costs down, but surgeons like very specific items when they operate. And in the past, hospitals would share supplies if needed, and if that meant taking care of a patient, in the OR that was waiting on an item, he has found that this really doesn't happen as often as it used to. But I'm from a bigger healthcare system, and we frequently do that. You have to leverage that system and negotiate multiple things that is needed, and that's with being compliant with contracts and reimbursement and private insurers, etc. Robots are landing in hospitals all across the world, including in the U.S. Robots are cost more than regular surgery. And then there's really no data for patient outcomes related to using the robot versus a more conventional method, per Dr. Rigari. So then questions, why would we use them? But modern day marketing and advertising and, quote, little to no scars and getting out of the hospital early and all those things that are really sexy to a patient and a family in a healthcare system. But also with that, surgeons have to learn those techniques. They have to be open to being more flexible and learning those. And that's hard because, again, with not a lot of evidence behind it. Let's see, robotic technology does make it easier for more complex surgeries, but per Dr. Rigari, it's a little too early to tell as far as the trend, but I'll tell you that we use them frequently at my hospital, and we just recently purchased a fourth one. Sorry, this is running a little bit over. Lastly, specialties can be picked related to money and what doctors see on TV, or what people see doctors say on TV, and his hope is that physicians can pick their specialty to help people and hope that hospitals that I work can be more patient focused and safety and quality over money and reimbursement and technology. So there are physicians out there that have different focus, and we may be asked to see them because of insurance and our PCP referrals. And so just thought to think about how you pick your surgeon or any other specialist or physician. Ask those important questions about outcomes and evidence-based practice, and that can make all the difference in the world for you and your family and their treatment plan. So I really recommend the book. It was a really interesting read and pretty quick. So again, The Cost of Cutting with Dr. Rigari. I'm sure I'm pronouncing that wrong, but thank you so much.